So the next session is going to be a very interesting session on the use of, we have a lot of drugs for the dry eye, and dry eye has always remained an enigma. So which drug to use, when to stop, what to add, when to use cyclosporine, when to stop cyclosporine, how long can you give cyclosporine for, and how to go about it. All these questions are going to be answered, so that dry eye as such is not a jigsaw puzzle for everybody, but you do understand in a mathematical and in a logical manner as to what to do with it. So this is a topic which is very ambiguous. What actually happens is, as soon as the new MR comes and tells you, please put this, we don't see what drug, what is the label of the drug, what the constituents of the drug are. They'll just come and tell you, sodium hyaluronate is the latest molecule, so put this. Trihalube is the latest molecule, so put this. So it goes like that. But I think there is a method in this madness, and there is a logical way of the way you are going to treat the dry eye. And if you do go logically, you would realize that your patients are actually not mad, or your patients are not off their minds. And there is a problem there which needs to be looked into. Often to these dry eye patients, we really don't give them too much of time. We just, prescribe a lubricant and that is it. But I think we do need to give them some chair time so that they are able to come up with their problems. It is important to know that symptoms may not be equal to signs, and signs may not be equal to symptoms. Sometimes you think they're complaining of nothing because they have nothing in their eyes, no signs to say so. But you realize that when you actually take the history and you actually examine that there is a problem. And sometimes there is a problem you are seeing on the slit lamp, and the patient says, no, I am okay, I have no problem. So I think the first part from the patient point of view is very important, because he has a problem, he wants it addressed. The second part from the surgeon point of view is very important, because there is a problem, and if you attempt to do some surgery, howsoever trivial it may be, the patient might jump off the fence and become actually problematic. So both the situations are important, and just as a prelude, I am going to just give a talk so that it sets the ball rolling for discussion. This is basically panel discussion and interaction. There is a seat there. I am going to be mostly standing, so somebody can come and sit there. So if we see the, I am actually thankful to all the people who have joined in, especially the cornea specialists and others at such a short notice. I informed them only yesterday. So DUCE 2 is here. DUCE 2 taught us for many years, but you know that DUCE 3 is coming now. In October this year, DUCE 3 is going to be released. And then we'll come up with our Indian guidelines also as to how we can extrapolate it. In fact, next week it is going to be coming. 29th October is the day when DUCE 3 will be released, just 2-3 days after our conference. So I have no financial disclosures, and I think people who are sitting here need no introduction to this definition. Everybody knows it. It's multifactorial, loss of hemostasis and tear film, hyperosmolarity, neurosensory abnormalities are also there. And this we have been flashing from time to time. I think important thing about this was only this, that signs is not equal to symptoms, and symptoms is not equal to signs. And that is where the dry eye problem is unique. It is becoming prevalent. It is becoming prevalent because of the climate change, becoming prevalent because our lifestyle is changing. And I think in times to come, it will become one of the major lifestyle problems, because all of us are going to be affected by the climate change, by the pollution, by the way we do things, which is majorly on the laptops, by the way we are in the environment, like air conditioners, blowers, etc. So it is here to stay, and only getting worse in the times to come. So I think we do need to do tests. Not all can we do, but some of the tests can be done, and these can tell you some insights into what is the status of affairs. You do ask triaging questions, because like I said, it is important. The symptoms are there, and then after the symptomatology, you do tests, and I think 3 important tests are the breakup time, osmolarity, the ocular surface staining. classify them into evaporative or aqueous deficient dry eye, and then accordingly treat. But I think very important is to know that that the mixed pattern is very common, which we underestimate. And of course, ocular surface analysis, new machines are coming in every time. We see that there are new companies who come in with a new set of machines, and then there is a whole jigsaw puzzle of machine. I think we can have one whole session on dry eye as to see what are the treatment modalities in terms of medications, and also what are the machines which are available, especially for the meibomian gland disease. So these are just pictures from ocular surface and OSA, that is the ocular surface analyzer. And after doing the tests, classifying them into subtypes, there are certain actions which need to be taken, and the actions are also well known to all of us. Education, of course, not only for the patients but also for the physicians. Lubricants of various types, lid hygiene and warm compressors, and free fatty acid in the DREAM study was shot down, but I think it has a role. And if you do tell patients to take omega-free fatty acids, I think somebody should do that study again to actually say whether it is working or not working. Then stage 2 management was there, of course, and it is important that you do give lubricants in this stage 2 management. In stage 2 also come your anti-inflammatory drug therapy, which could be levetiracetam or could be cyclosporine before controlling it with topical steroids. Stage 3, people give oral secretagogues or therapeutic contact lens. And stage 4 is topical steroids, or even surgical punctal occlusion or other surgical approaches can also be done. So the question is, which tear substitute? So it is not the tear substitute which the last MR has told you. You should know the cause of the dry eye, the severity, and the formulations, and the cost and the affordability is also a major issue. Essentially, there are 6 groups, and all the company people, MRs who come, they tell you all of the drugs can be classified into one of these groups. Important thing is that we should know which drug, when to start or when to stop or when to give. So the dry eye could be mild, could be moderate, or could be severe, and depending upon the severity of dry eye, if it is mild, you start with 0.5% CMC or 0.3% HPMC or carbomere. If it is moderate, then polyols or gelling agents. If it is severe, then 1% CMC or hyaluronic acid with osmoprotectants. If it's still not getting treated, then you use combination of drugs. That means you will use a CMC or a polyol agent, or you could use a CMC or a hyaluronic acid, or you could use a polyol agent with hyaluronic acid. So you combine the two, go totally preservative free if it is more than 4 times a day, and ointment and gels in the bedtime also. So this is just to show the same. Now topical cyclosporine A, we've known it for years now, is the next line dry eye therapy for those who have failed the conservative measures. Of course, you have to first control the inflammatory part of it with the topical steroids. So if the inflammation is there, and what does the inflammation mean? That the eye is red, then you have to control it with topical steroids followed by topical cyclosporine. Other immunomodulators are levetiracetam, which is again a new kid which is on the block. Cyclosporine action we all know, and there are various formulations which are available to us. Now there are challenges with the anti-inflammatory agents like steroids, cyclosporine, etc., which are currently available, and these challenges are which are as follows. So most of the patients, if you give immunomodulators and if they're stinging because of that, will discontinue cyclosporine or would discontinue the drug therapy. And 70% of the cyclosporine A patients using 0.05%, and 64% of the patients with a levetiracetam discontinued the treatment within 12 months of initiation, and the discontinuation rates were associated with burning and stinging and lag time between initiation of the treatment and the symptomatic relief. Now this is a study which shows that levetiracetam action takes much longer, and it failed to show significant effect at 2 weeks, and topical cyclosporine 0.05% again starts to act only after 6 weeks, and the maximum action occurs much later. So the problems with the existing formulation is that they are thermodynamically unstable with poor ocular tolerability, and they are basically in the form of suspension, may cause blurred vision and low bioavailability. So the cyclosporine that we are going to talk about is Cequa, which is based on the N-cell anatomy or the N-cell technology. So it has a hydrophilic shell which is protective, which allows for transparent transport through the tear film onto the ocular surface, and it has a hydrophobic core which is secured inside, which prevents the encapsulated cyclosporine from being released until after penetrating the aqueous layer of the tear film. And with the N-cell technology, delivers the cyclosporine because N-cell encapsulates, so N-cell penetrates, especially the, and as soon as it penetrates, this active cyclosporine drug comes in contact with the ocular surface, and the N-cell technology encapsulates, but it allows it to permeate the aqueous layer of the tear film as well. Some of the studies which we have, which have been done on this Cequa, or the cyclosporine which is made by the N-cell technology. So this is an animal model which clearly shows that there is 3 times increase in the conjunctiva and the cornea with Cequa as compared to the other agents such as restasis and 0.05% cyclosporine. There are various phase studies which have also been done, and this is again a phase 2B, phase 3 study design where Cequa versus vehicle versus the 0.05% cyclosporine were compared, and it was found that this provides action which was as fast as 2 weeks, and Cequa improved the total corneal staining after 14 days. Then in phase 3 study again, which looked at Cequa versus vehicle, because what if vehicle is doing the trick, it was found that there was reduction of in the total corneal staining at 1 month, and subsequently with Cequa, also patients reported reduction in the symptom severity. Visual acuity was significantly improved at 2 months, and significant corneal clearing was seen with the Cequa, with improvement of the tear production at 3 months, which nearly doubled, and 65% of the central corneas remain absolutely clear. Now, this is the real world treatment patterns. I wish we could do such studies. Unfortunately, we cannot. This was basically to see through the insurance that people were taking Cequa or were taking lifitegrast or were taking other agents, as to how many of them discontinued. And it was found that the Cequa was used for almost 12 months, but lifitegrast was discontinued at 8 months, and 0.05% cyclosporine at 7 months. Again, more than 95% of the patients will not complain of any pain, etc. with Cequa. Patients are quite comfortable, and the most common adverse event that has been reported after the installation is a little bit of pain and conjunctival hyperemia, but no patient has discontinued its use despite this. Now, this is the long-term safety study where the treatment arm was randomized in 1:1 ratio with vehicle and Cequa in 744 patients. So that's a large group, and cyclosporine 0.09% was used up to 50 weeks. So again, notice that overall Cequa demonstrated efficacy in improving the objective signs of the dry eye, the tear production and the conjunctival staining or corneal staining in the worst eye during 12 weeks treatment phase. Adverse events again, and there were hardly, like I said, hardly any adverse events because the patients tolerated Cequa as compared to the other agents. Also in general, patients do tolerate Cequa. Now, treatment with Cequa or with restasis, this is the change in the tear production, and this was done in an animal study where it was shown that Cequa twice daily significantly improved tear production versus restasis, which was given twice a day on day 45 and day 60, as also can be highlighted in the chart. Concomitantly, of course, you can use artificial tears, and it alleviates the symptoms and improves burning, stinging and irritation on cyclosporine A installation. Concomitantly, you can also use topical steroids, as has been highlighted in these studies, and it was found that they do have a synergistic action. So it is safe to combine it with topical steroids as well. This is a little far-fetched, but I think will have a role, especially if you're using premium intraocular lenses, because it helps to improve the higher order abrasions, especially in those dry eye patients or borderline patients who might jump the fence and have manifest dry eye disease after any surgery, whether it is cataract surgery or it is LASIK surgery. Just to show some of the pictures as to how cyclosporine behaves. So this is 2 weeks after topical cyclosporine. The inflammation does disappear on impression cytology. Also the same can be seen where the number of the goblet cells you can say changes after the CEQA therapy. This is again topical cyclosporine A, where patient it has been used. This was a case of one-eyed patient with the dry eye, which again shows good effects. A patient of rheumatoid arthritis with dry eye and filaments, which completely disappear, and this is almost close to 1 year with therapy. And this is yet another patient where you can see that the typical staining is much reduced with this. So to conclude, I think CEQA is here to stay. From day one, there is no or mild installation site pain for more than 95% of the patients. After just 14 days, there is improvement in the corneal staining. At 1 month, there is a significant decrease in corneal staining and reduction in the symptom severity. There is improved visual acuity. The central corneas, close to 3/4, are clear and tear production nearly is doubled. And after nearly 1 year, more patients will still use CEQA as compared to the other drugs. Of course, the most common side effect is a little bit of stinging, but patients in general don't discontinue the drug. So to conclude, I think dry eye disease is a complex entity which varies in severity and character from patient to patient. The management of dry eye disease is more of an art rather than science. Stepwise management is required, and simple over-the-counter drugs are available, but I think more advanced drugs are also there which should be looked into. Synergistic therapeutic approaches and adaptations are often required, and of course, you need to follow up these patients closely. I would like to invite all of you to APO, which is going to be the mega event of the All India Ophthalmological Society, because APO is coming to India after almost a decade. After losing the bid 3 times at the Asia Pacific Academy of Ophthalmology portal, finally we won the bid 4th time, so it is going to be at Yashobhumi, a coveted event. I don't think it will happen again, at least in my lifetime. So it is going to be at New Delhi, April 3rd to 6th, 2025, Yashobhumi, which is the Asia's largest convention center. So it is the state-of-the-art convention center. So do attend that, and in case you want to participate, do let me know. So thank you very much for your attention. And the whole thing is now open for discussion. We have an expert group of panelists here. Each one of you who wants to ask any question is welcome to ask any query or question. Otherwise, I will start asking you questions. No, I am not in a classroom mode. But
what ma'am has said, that this is very patient friendly, and people have not discontinued therapy because of its because previously used drugs. The pH problem was there. Probably they were having a lower pH, and this CEQA has a pH which is very much resembling the tear film pH. It is around 6.2 or something to 7.2. So this is very much neutral pH for the matching the tear film. So that's why probably the patient acceptance is better.
Yeah. I think that is also a thing, and I just want to know. I want to know Dr. Arun Jain's opinion on CEQA, as such, and otherwise in general about dry eye patients. How do you treat, or how do you go about it? Because this is the algorithm that we have.
So we have been using cyclosporine molecule for maybe almost more than 2 decades, not more than 1.5 decades. So over a period, so many molecules have come over. 0.05, 0.1, 0.9. So there are so many molecules available, but my indications for starting cyclosporine will be, and it's also justified in literature also, that Once you are, I mean, establish the cause of dry eye. First of all, we have to establish is it just a purely a tear deficient or a oil deficient or a combined mechanism. Because nowadays we are seeing a lot of patients with the computer vision syndrome and especially contact lens users where meibomian gland disease may be quite in a large amount, I mean, in quite large proportions, though seen more commonly after 45 years of age in females and 60 years in males, when male or female menopause happens and hormonal trophic effect on the meibomian gland is gone. But we are seeing now MGD more and more in computer vision and contact lens users because their screen time is so much, their blink rate goes down, and most of the time they are blinking halfway. So most of these patients are over a period of maybe 10 years going into a disuse atrophy of these glands. So most important thing I advise to these people, the youngsters as well as old one, the blinking exercise, 20 by 20 rule. After every 20 minutes, take a break, look at a distance, and blink 20 times completely. That is very important because until and unless we exercise a muscle, it will go into disuse atrophy. And normal physiological expression of meibomian gland happens only when there is a complete blink. When there is a complete blink. So complete blink, so they should be in a habit of blinking completely and one or two squeezes also, so that their gland over a period of 10 to 15 years doesn't go into atrophy, because after that once they atrophy we are just flogging a dead horse. You can just do a replacement therapy, you can't treat or revert the disease otherwise, because once they go into atrophy we are only left with the substitute therapy. We are not going to bring down to the normal milieu or the ocular surface homeostasis. So that is most important. I tell them this is the most important thing which you have in your hands. The rest of the things, once you diagnose it and once they are on the verge of moderate disease, it's better to start cyclosporine, because all said and done, rest of the drugs which are not anti-inflammatory, I mean, which are not increasing the underlying cause of the disease like ocular surface inflammation and other things, they are just a substitute for things. So it is better to start cyclosporine earlier than later, so that you preserve the normal milieu of the eye as well as prevent other things. And one more important thing which I wanted to say is
I think, sir, that is a very important message,
Yeah.
that topical cyclosporine should be started earlier than later.
yeah.
Because we should not keep waiting that, patient is going on lubricants. I think that assessment is important, that rather than early we should start it earlier, because otherwise, like you said, if it goes into a disuse atrophy kind of a thing, then later on the things become non-salvageable.
And one more point is just to break in the patient, like discontinuation of therapy is quite important, as is evident from the presentation, and sometime
So,
the
sir,
issue-
do you think, like we have tachyphylaxis with the anti-glaucoma medications, there is some kind of tachyphylaxis even with lubricants? Because once the patient is given any, you change, say, patient is given CMC and then you suddenly change to sodium hyaluronate, then, patient starts feeling better.
that's
So, I don't know
very
how many people would
difficult.
agree with it, but
Course, whenever I start with this, I always start with the loteprednol, and like in last few slides you said, for last 20 years I am doing like this, because that helps in breaking in the patient to the use of cyclosporine, that irritation. I tell them to put a drop of lotepred LS 0.25 or 0.2% and wait for 10 minutes and then put the cyclosporine. That takes
so,
away
yeah, so
stinging
stinging.
thing,
So, I
as
think
well as addresses the underlying, like it takes 2 to 4 weeks time for the effect to come. So it's like breaking in a new vehicle. It's sort of breaking in for the
just like when you
cyclosporine.
take a new car, so
Yeah.
there's a speed limit. So,
Yeah. So that's my way of treating
Yeah, so
this.
I think there are two ways. My way of treating stinging is that I ask them to put a drop of lubricant and then
That of
put
course,
the drug. But then the flip side of that is that you are diluting the drug a little bit. Any other opinion on this?
So
How
wait
to
for
take
10 minutes.
10
So
minutes?
that at least 5 time is the clearance time for.
Ellen, any other?
That also has to be explained to the patient.
So then, if we say the element of rubbing, then I think Dr. Arun Jain's hypothesis, makes seems to be more logical, because once you put a topical steroid, then your rubbing also is not going to be there. So the third thing is that you cool the cyclosporine. So I think, can we cool Sequa? I think that is not a problem at all. So putting it in, so that is why they are getting smarter, that first initially only you tell people that you put it in the fridge. So the Sun Pharma people are also here. How many of us have switched from Restasis to Sequa, or Sequa to Restasis? From Restasis to Sequa, and you think that the results are better with
For sure.
Sequa as compared to Restasis?
For sure.
Manpreet? So was it a commercial compulsion, or was it a scientific deliberation?
The second we are trying is in post-refractive surgery patients from day one, even before they complain. And the compliance is good, and the stability, the complaints, etc., patient dissatisfaction that usually is there to some element in all refractive surgery patient has decreased.
So how many of us are giving topical cyclosporine after refractive surgery, day one? So Ellen is, Pranita is, and Manpreet is, and nobody else? Sir, you don't get? No, that, do you think it also
3 months,
takes
3
care
months.
of the dryness that is there post-operatively? But I think the lubricant,
Takes care.
More than the dryness part, what I have noticed, particularly I am more into surface ablations.
okay, so
It is.
more for surface ablations
So
than for.
the comfort as well as the haze, what the patient complains in the first 6 weeks, it's much lesser when we started cyclosporine. Even before Sequa came in, I was using cyclosporine. But once Sequa came in, it made it very easy.
So,
Surface ablation.
Actually, we have done a randomized control trial of placebo versus cyclosporine versus lubricants alone, and we have found cyclosporine to be better in terms of ocular surface stability. Of course. So in post-refractive surgery patients only that trial was done.
so in that trial, Sequa was given for
So
how
it was
long?
before Sequa. It was cyclosporine.
So it was a
0.05%.
pre-marketing study you were doing,
Not with
Manpreet?
Sequa, just cyclosporine.
Just
So the
cyclosporine,
efficacy of
0.05%.
Yeah,
Yes,
yeah.
I do remember.
Sir, another thing is
That is why we followed up till 6 months. After the steroids stop after a month.
Okay, so you followed, and the results at 1 month vis-a-vis at 6 months were
Yes.
corroborating.
So Sequa gives us sustained benefit beyond 3 months.
Mike.
Yeah.
sir, I'm coming to that point only, sir.
Until
Now-
unless there is some pre-operative like chronic contact lens, already there's MGD or something, it may not be logical. Because as such we are saying that effect of these drugs come after maybe 4 to 6 weeks time, and I don't know how many of you are using it over a 1 year period of time post-refractive surgery, so it doesn't make sense to me.
Minimum 6 months.
Another group of patients is the patients undergoing premium IOL surgery, and preoperatively you find that they have moderate dry, moderate to severe dry eye, and these are the group of patients who are totally dissatisfied after cataract surgery in spite of giving them good vision. So I think we can also think of starting in these group of patients besides just lubricant, because anyway the dry eye, if they have preoperatively, it gets worsened and the patient. So these group of patients undergoing premium IOL surgery can also be considered for using, rather than later on when they are totally dissatisfied and then you bombard them with so many drugs.
And then the
We can.
largest subset of patients that we are giving cyclosporine
Mike.
currently is those of allergic conjunctivitis and VKC, which in contradiction to the Western literature, our Indian patients are different. The amount of VKC and allergic conjunctivitis that we see here is so huge, and on and off steroid, as we all know, is not advisable. So I think the largest amount of patients for which cyclosporine is currently being given is VKC and allergic conjunctivitis, then coming to dry eye, and
Okay.
then coming to refractive.
Okay, so I think haphazardly, but we've covered the indications. So
Ma'am,
dry eye,
one more indication that I have found, ma'am, that which I have found good results with CEQA in particular is patients who have subepithelial infiltrates, especially recurrent ones. So maintaining them on this drug actually decreases the need for, because it's decreased
topical
recurrences,
steroids.
then no need for giving other steroids in such cases. So that's another use of CEQA or
Ma'am, even
cyclosporine.
in primary and secondary Sjogren syndrome, because there is an inflammatory character of these conditions. So these CEQA, especially cyclosporine, it acts as an immunomodulator, so it helps in decreasing the IL-2. So primary and secondary Sjogrens are very important. And VKC, as Pranita said, VKC, it dilutes the inflammatory mediators as well as acts as an immunomodulator. So I'm giving in lots of VKC as well as lots of keratoconus patients also.
No, are you giving the CEQA for keratoconus?
Yes, ma'am. Yes, ma'am.
Or
So keratoconus
are you
also.
giving, sir? This is a controversial thing because
Well, we
all
may
keratoconus.
give it, but is there somebody has conducted some study? Does it really help? Only then there has to be some evidence to it. Though now all this is like diabetic retinopathy, keratoconus, all are said to be inflammatory disease, but does it really help in that way? We should start steroids in diabetic retinopathy people also. So I don't know. This is the house is open.
no,
I don't
because
find any evidence to it.
inflammation is being,
Is
you
targeted.
know, implicated for all these diseases. So the
Yeah, so I don't know whether
so
it's
we
useful
you know
or-
crossover. We use anti-VEGFs for corneal
No, but
diseases, and we use.
I would like to comment one thing, like patients of Sjogren, before you start, you start these cyclosporine early, but you must refer the patient to a rheumatologist until and unless you control the systemic disease. Local drugs are not going to be effective at all, because you are doing just superficial this thing. You have to control the inflammation throughout the body, the gland, and everywhere its antibodies are there. Otherwise, they are in the blood. They will keep on attacking the ocular surface. So systemic control of the disease is most important. I have seen so many patients of Sjogren where for years together they are putting this thing and hardly anybody addresses the systemic disease.
Before the drug was launched also. It's stinging.
At all tolerable. In the corridor, we could recognize that this patient has been given cyclosporine in castor oil. Then I tried the in-aqueous preparation from the injection. That was tolerated, but the efficacy is a problem because we know the nature of the drug. Then these commercial preparations came, and they are reasonably well tolerated, except depending upon the patient, depending upon the preparation, and depending upon the regimen which we can always use, like we can use a drop of steroid, or we can use artificial teardrop after or before, whichever way we like. But what difference I have found is that after using CEQA, patient used to ask, what is the benefit to me? So we have to convince that you won't get any immediate benefit, but it's a long-term benefit. It will control the inflammation, your surface will be not worsened, it will be stable, this thing, that thing, which patient doesn't understand. With the introduction of this drug, what I have found is that some of my patients, they have dramatic symptomatic improvement in their symptom, and that too in a very short time. That was surprising. And cyclosporine as such molecule is so good, as Professor Jain and Professor Namrata has pointed out, that it does increase the tear formation. Because some of my patients whom we whom we gave artificial teardrops plus cyclosporine, some of them are using only cyclosporine twice a day or once a day, and that's all. And they are so happy, and they don't come to us, and only when we ask, you are coming after 4 years. See, I'm very well with this.
So we have patients who are on cyclosporine for years together. This happens only, they have crystal clear cornea. This happens if you put them on cyclosporine early on. Still we are using cyclosporine in advanced case of Sjogren, where biopsy of the gland and everything show it has atrophied. There we are using it for their anti-inflammatory steroid sparing effect. Even in advanced meibomian gland disease, we are using cyclosporine for their anti-inflammatory, not for tear flow increase effect. So they do have a role, and like you said, castor oil, it's stinging. So we did the study way back in again 95, before even the FDA trial started. We started with 2%. We used to prepare in PGI pharmacy in 2% corn oil. So, and we did a crossover study for 6 months with the vehicle, and the results were good. But at that time, FDA trial results came in, I think, 2001. Nobody will accept our study. So we sent to so many journals. So, but ultimately, after this study was published 2001, FDA trial.
Everywhere
in
it was.
2007 it was accepted. So now all studies which are done properly, they will quote our
quote
study.
that study.
But for
So-
10 years we couldn't publish this study.
So we,
And
yeah, so as far as cyclosporine is concerned, Cequa is there, Restasis is there.
Yeah.
But there are other formulations also, like nanotears is there, and with no financial interest in anything. How do you, I mean, when do you, right now we are discussing Restasis versus Cequa, but what is the role of other cyclosporine formulations versus Cequa?
So, as I said, everybody can't afford, the financial implications do come in. Many of the poor patients do
They are
not,
not able to afford.
they are not able to afford it, and for some people 3,000-4,000 maybe the monthly income. So we told them, I have been using
Cheaper
cyclosporine
cyclosporine.
0.1%
So-
for
mm.
maybe 20 years. Deepak knows, and
So-
they also doing well. I mean, it's an alternative to
So Deepak,
this thing.
only because of the N-cell technology, we should give Cequa and not your cycloimmune.
No, of course, you have highlighted the quicker achievement, better this thing, dropout rate is less, so all those things are there.
So when Cequa came, I mean, frankly, almost about 2 years ago, there was a challenge in shifting patients from Restasis to Cequa, because even we were not, knowing what the results are. So how many of us have switched? And to tell the patient who's already doing well on Restasis, you tell him now from today onwards you shift to Cequa. He'll ask you why, but why should I say shift to Cequa?
So we try to switch from not from Restasis to Cequa,
But
but from cycloimmune to cycloimmune.
From cycloimmune to Cequa.
Cequa.
So it's their loss
Some
anyways.
of them say they are happy with cycloimmune.
Yeah.
So I don't know whether it was financial reason or otherwise.
No,
They
actually-
had some study.
My question was always that we are also increasing the concentration by double. So,
Yeah.
So if you're claiming it to be better, that was my question always to them, that if we are claiming it to be better, it's also double the strength. So how do you justify that? So they say that's because of the response.
No,
basically.
I think it is mainly because of the permeation, which they have shown that 3 times more it is in the conjunctiva. But you've
Because
not
the
compared
educated patients
cycloimmune
wouldn't
with
ask
Cequa.
that we're doubling the
First
Yeah.
FDA trial compared the two concentrations.
True concentrations.
So they said the effect is same,
Same.
but maybe the side effects are little bit more with 0.1.
So they went on with
So the
0.0.
effect are same. So maybe I sometimes like in severe VKC cases, I use 0.1% even 3 times initially.
Yeah.
Maybe Because there are so,
So-
much of watering, how much of drug stays in the
Yeah,
eye,
so I think that is what we've not talked about, the allergic eye disease part. And I think we use it lot more for allergies than for dry eye itself. More so because for allergies there are not too many drugs which are available, so we have to resort to the other alternatives like cyclosporine. Lifitegrast has also come, and can we discuss that? I think you will be okay with it. So I think for the sake of science, we should discuss lifitegrast also, which is the new kid on the block. It is also supposed to be good. The only problem is that it is hugely expensive,
It is very, very
very expensive. I don't know, in my setup, I can't seem to find a patient for lifitegrast, although the trial was initiated through us, but I don't know how anybody is using lifitegrast. Not using lifitegrast.
It is all cost-based.
Yes.
So
Personally, I think I've reduced using tacrolimus after Sequa. What about others?
no, tacrolimus always is a good drug,
Yeah.
but somehow it never remained as a first line anti-inflammatory therapy, always remained as a second line anti-inflammatory therapy. I think there are no studies or trials, or maybe there are head-to-head which have compared tacrolimus with cyclosporine. But for me, tacrolimus was a go-to drug as a second, maybe because of the availability, because cyclosporine was so easily commercially available that it became easy for the patient. But then when things are not responding to cyclosporine, we do resort to tacrolimus.
Even cost-wise, among the immunomodulators, tacrolimus tends to be cheaper.
Cheapest. You know, sometimes the expense also puts you off. If it is too cheap, then you start thinking, you know, it's going to work or not going to work.
Also the indications
Yes.
differ.
Amit, you can come here. There's a seat here, Amit.
That is the reason why it didn't take.
What I experienced with tacrolimus is when we give the tacrolimus ointment, patient complain of a lot of stinging, burning sensation and irritation. Whereas with cyclosporine, especially Sequa, I mean this effect is gone. So when we shifted from tacrolimus to Sequa, patients, even though the cost has increased, but they are more happier to do it.
Ma'am, we are talking too much on the cost, but when we compare cyclomune to Sequa, the cost difference is not much. Not at all. In fact, Sequa will work out a little bit cheaper if the patient uses it properly, keeping it in the fridge. That's number one. Number two, multiple use of that single vial. Usually we use it for 5 doses. Some of them even beyond that, which is 2.5 days almost.
Because cyclomune vial is 2.5 ml vials.
No, actually, if the company for the cutting down the cost, what they have
yeah,
charted
cost
is
wise it comes
one,
almost,
one
sorry.
the thing of Sequa, not an amp, but the Unim. So they tell you if the patient can't afford it, you can ask them to use it for 2 days or 3 days, and the cost comes down. But it's an off-label use then.
In that case, even tacrolimus is an off-label use.
Tacrolimus is off-label. Although Orolab has started manufacturing tacroment now.
Technically.
The kids.
So I think cyclosporine is found to be safe in children also. The
Um,
very fact that systemically you cannot find its levels in the blood, and there is, I don't know which is the longest study for children, but in general found to be safe to use in children. I have used it, a lot of it in children, especially for allergies, but I have not found any significant. Maybe in your this thing it is written in Sequa age.
Keratoconjunctivitis, their brand, Vercasia, 0.1 percentage. That is 4 years and above, and in VKC it is approved indication in US now.
Okay.
So it's very well
So
acknowledged.
4 years and above. I have used it in a child as young as 6 years, so that I can say. But 4 years is something you can use that. We are, yeah. So although we talked about keratoconus, and I said that there are no results which have substantiated that We are doing a study where in formiferous keratoconus we are at least in one eye using cyclosporine, in the other eye, cross-link the patients, but I think you really require long-term studies to say so. I think Dr. Rohit Shetty once, for the first time suggested it could be used, and then at that time people, I remember still that meeting which was held in Bangalore, people, were a little skeptical about it, but the studies are coming up even with this.
I have a question for the experts, as in how long do you use cyclosporine in one go? As in, like Ashok Sharma sir said, that patients use for years altogether. So when it comes to safety of using, or if there's a drug vacation period that you give in between, maybe for a month and then restart, anyone?
The brochure for prescription of CEQUA says the safety and efficacy of CEQUA have not been established in pediatric patients below the age of 18.
18.
Different drug you were saying.
No, he's saying somebody else, some other company has taken.
Okay.
Yeah.
No, which one we should follow? The hearsay or the written proof?
No, I think we should be doing, this is a food for thought.
It's
We
a
can do a
off-label,
study
you
on
have to, if
use of
you are talking
cyclosporine
of
in children.
US, then you have to take a special consent.
But many children with systemic allergies, they are on oral cyclosporine also. It's considered to be safe in children also, and in pediatric department they are using it in children like oral cyclosporine and as early as 5 years and above. So oral cyclosporine also is quite
But
safe.
of course they will discuss the side effects and everything. no?
Definitely, sir.
They have
Definitely.
to know. It's a known thing. You can't prescribe a drug without telling the patient. No? You have to discuss it.
So oral,
Otherwise it's unethical.
Oral
Either it's
cyclosporine-
unethical or you take a presumed consent or take a informed consent.
so I would like to add, oral cyclosporine in children is prescribed by our pediatric rheumatology department routinely, but they say that it leads to, oral cyclosporine leads to gingival hyperplasia and hirsutism. So it is a particular concern in girl child. So that the trough levels have to be taken into consideration, and they now prefer oral tacrolimus, in fact, if they have to give a oral medication, oral immunomodulator. So orally, tacrolimus is slightly better, more potent as well as less side effects.
So I think the next thought process would be, when do you take them off, or do you ever take them off, or do you continue them lifelong? Dr. Ashok Sharma sir said that we can, give a drop for years together. But have you taken off, has anybody of us taken off the patients off cyclosporine? I think few patients.
3 months time break, especially for allergy patients when the season for allergies is not there. Giving them a break for 2 months at that point of time and restarting when the allergy season picks up.
So for allergies it could be seasonal, but what about for dry eye, because that's kind of chronic?
Patients who are having recurrent allergies and where you have to give at least 2 courses or 3 courses of steroids in a year. If the child is having, then immunomodulator is good enough for these patients.
Thank you.
So in that
Mike.
crossover study which we did in 97, because we should know the half-life, like it takes time, almost 4 weeks, for tissue levels to build up. So even after stopping cyclosporine, it takes time for the level to go down. Which takes about 1 to 3 months time. So the residual effect of cyclosporine also remains.
For 3 months.
So, but I don't think there are any
I
paper
think
on this.
once we treat patients with severe dry eye or patients with autoimmune disorders, once we give them full treatment, like initially they may require autologous serum, punctal occlusion, everything, but if they follow sincerely the course, the ocular surface improves, and gradually, like we can do tapering of one drug or the other. Like the autologous serum is very cumbersome to make, so we take off that, and subsequently still the patient is better. We can think of stopping in between, like the patient themselves also stop in between cyclosporine or intermittent course. And but I have seen that if they decrease the drugs and then after a certain period, again the disease starts worsening. So you have to have a long-term follow-up of these patients.
So we have many patients who over a period of 6 months to 9 months they stop treatment on their own. So after stopping treatment 3 to 6 months afterward, then again they come back.
So the
it
window
all
period is 3 months, basically. After
Yeah.
stopping, you cannot say that
Yeah.
you
Yeah.
should follow them up for 3
Yeah, so
months
I think 3
and
months
6
is-
months, and then see whether, you know, it is...
yeah. So
And
if they are-
sometimes we advise them like next, they have to purchase the next box of this thing, that you stop in between for a month or so and then take a break or something. So we can do that because it doesn't worsen that fast.
There have been instances also, for example, I have patients who used it for 2 years, then stopped it themselves and not come back, like you said.
Yeah, there
Or
are many
used it
patients
for
like-
5 years and then, you know, not come back and not taken the drug also. So there have been instances. So maybe it does break acutely the inflammatory vicious cycle and also
maybe
chronically.
it breaks the cycle, or maybe the severity of the disease is different in different patients.
Anybody would, yes.
Yeah.
Ma'am, this topical cyclosporine can also be used in post-keratoplasty patients, like especially for patients of therapeutic penetrating keratoplasty, especially in the fungal ones, in which we are not able to give the steroids. So, for the SCUT trial, we were giving like in that, but in the
So
fungal
in fungal keratitis, and I discussed this with Sun Pharma also, that in fungal keratitis we have completed a thesis, MD thesis, adjuvant role of topical cyclosporine, I mean of course with the antifungals, a randomized control trial, and we did find that there was a significantly better results as compared to those cases where we were not giving topical cyclosporine.
That is a known use of cyclosporine, and I mean especially post-herpetic this thing, and there's enough evidence in literature that patient suffering from herpes keratitis or herpes zoster keratitis, they usually have sympathetic dry eye also in the other eye, and using cyclosporine drops in these patients in both the eye have improved the ocular surface in both the eyes, and it does increase the lateral flow in these patients.
Yeah.
So I have been using this also for so many years, you know? Especially herpes zoster, the cornea is very
Anesthetic also and
anesthetic.
very dry also.
The neurotopic.
I have started using cyclosporine even for my post-trap patients.
Post-trap
Post-trap
patients, now this is a
also.
new
So
indication.
this is something, that's what I wanted to share this. Post-trap, when we see that the bleb is going to fail, I've started them on cyclosporine maintenance therapy instead of giving them steroids for longer duration. So basically the most common reason for failure is the ocular surface, which patient is on chronic medication. So starting cyclosporine helps in formulating the ocular surface, and the chemical cascade is stopped. So the blebs behave better. So I'm just started that, and we'll look for the literature search also.
Even cases of resolving infectious keratitis, they tend to have some dryness. So we are doing a study looking at dry eyes looking for, you know, parameters of dry eye in resolving microbial keratitis, because I feel that they tend to become dry after the resolution of the corneal ulcers once they. So maybe
after the epithelialization.
after epithelialization, when they kind of resolve, then they tend to become dry. So maybe, so we are expanding indications of topical cycles.
Graft rejection also you did a study.
Yeah, so graft rejection, like at the same time when PGI started, we also started. So our first study, in fact, of topical cyclosporine was for 2% was graft rejection, both for the treatment of graft rejection, and at that time we didn't find that it helped. I mean, that was a negative study. So sometimes the negative studies are also very important. So in terms of graft rejection, there was no difference. Then we did a study for prophylaxis of graft rejection, where this was done by Dr. Rajesh Sinha, where we gave topical 2% cyclosporine for preventing the graft rejection. And there marginal difference was seen for those cases where topical cyclosporine was given. And now, of course, and then of course, the FDA came up with the cyclosporine, and then whole gamut of cyclosporine, started. So this is a question for the manufacturing companies. How much of manufacturing company, how much, I'm sure Sequoia has really picked up, and how much of the market have you been able to capture from other companies as far as cyclosporine is concerned, minus cycloimmune? Okay, let us be more diplomatic, expand the market.
Why I'm saying so, because maybe earlier cyclosporine, it is not that it was bad. They were already doing the job. Only thing is that it's a better formulation has come which gives you a quicker relief, the tolerability is better over a period of time,
So,
you see a better result.
so people tend to use it more.
Absolutely, yes. So it's ultimately at the end of the day patient's benefit.
Also, you should do a survey how many general ophthalmologists are using, how many cornea specialists are using, to know how much it has percolated into the, you know, general ophthalmologists.
We
mind.
had targeted around 70, 90 doctors across the country, madam, who are prescribers of Restasis, and we converted around 1,200 so far. And you know, others also doing, giving the prescription for both the products as of now, and we are very confident that shift will take place very soon.
No, for the effort that you're doing, of course, yes, because there are two drugs to any, I mean, there are two aspects to any product that comes in. One is that it works or it doesn't, and fortunately this works very well. And second is also visibility. There are so many products in the market, you know, which are actually there, but you have to put them in the proper perspective, otherwise it doesn't percolate. And I think both these activities are going on, and so it is here to stay, and it is likely that it will supersede or already has superseded other drugs which are there in the market.
He has a question to our dear Dr. Friend has a question.
May I have a question?
Yes, sir.
I also work in lovely professional university. Their students are using, their screen time is very more, either using laptop, projectors or mobiles. Mostly they are using 7 to 8 hours. So I get about 60 to 70 patients daily. So they can't leave the laptop, although we tend to use 20-20 rule follow, but they are not. For them, I prescribe carboxymethylcellulose
Lubricants.
with glycerin, ointment. No drops works in that. So morning and evening, and wherever I find some inflammation, then I give Ketarolec eye drops twice a day or thrice a day, and warm compress at night, and maybe afternoon, wherever it is needed. So can you guide me? What can I do better than this? Well, cyclosporine is best, or my line of treatment is best?
No, so I think sodium hyaluronate would be better after you've given CMC and, you know, you want to give them extra comfort. So sodium hyaluronate is a drug which is to go to, a molecule which is to go to. And as far as glycerine is concerned, we used to give glycerine in the older times. It was used a lot more, which we don't use now, for the fact that there are not commercially available preparations of glycerine. And I don't know whether to say that we can use Sequa for, you know, for lifestyle kind of a thing, for computers, etc. I'm sure there are no trials for this, but something which may be, which, you know, maybe someone can look in future. So you can change the molecule to from CMC, HPMC to a more.
I feel glycerin is more effective in all kinds of dry eyes. Carboxymethylcellulose doesn't work.
So I think anybody is having any other experience with.
I am telling the practical experience.
Yes, surely. You wanted to ask a question?
Yes, ma'am. This summers, ma'am, I think I stopped giving tacrolimus and I've been only using cyclosporine. I think I prescribed them around 40 to 50 kids above 6 years. And just sir has told me that the systemic absorption of that systemic dose of cyclosporine. Sir, I just want to first know one thing, that I think that dose variation, we giving oral cyclosporine and topical cyclosporine, it definitely varies.
No, the studies are there where it has been shown that topical application in the eye doesn't lead to significant blood levels of the cyclosporine.
And second thing, that I didn't notice any stinging thing in any of the child. So I'm surprised, because parents are very conscious if the child has problem. Maybe because to every parents, I'm ensure that everybody has to keep all their anti-allergy drugs into the fridge. So that and second thing, I want to ask a question, that I have a patient of viral keratitis. I have prescribing him this ACV twice, and every time I lower his steroids, his viral keratitis comes up. So I'm just asking that because of that suppression, we can continue that ACV twice, but can we start this cyclosporine? But it's just a question in my mind. That if
So the
we are
question
giving
is, patient who's having herpetic keratitis
while
is already on a prophylactic dose. Can we start topical
cyclosporine,
cyclosporine?
because the concept of this cyclosporine is that we don't want the side effects of the steroids actually. So I'm thinking, I'm just want to ask the panelists.
A dry eye patient with a
no,
herpetic.
not dry eye, ma'am. He's a patient of viral keratitis.
Viral keratitis.
Appendite starts appearing. So in oral ACV is there. I have lowered the steroid from 0.5% to 0.2%. He has been doing well. He has shown everywhere, I think. And right now he is currently doing well. But now I'm asking.
Viral keratitis?
No, it's not uveitis. It's
No,
it's
stromal keratitis.
Stromal keratitis. Now, sir, I'm thinking that if suppose I stop 0.2, I've kept in 0.2 a little. If I stop that and then start with cyclosporine, because for how long you can keep steroid? Will it work?
So normally when you have stromal keratitis and you start topical steroids, then it works dramatically, very quickly.
It has been worked, it is working well, but
and
if
then
you
it
stop
recurs.
steroid, again it starts coming. And
So basically, the recurrent stromal is basically immune thing,
Yes.
not an active viral this thing. So if steroids are working, you can use cyclosporine as steroid sparing agent.
Yes, sir, this is
That
I want to ask that.
But there is a catch here. When the cyclosporine was first introduced, there is a study that's included there. Reactivation of herpetic epithelial keratitis was found.
So you have to be sure that there is no epithelial component, but having said this, you never know.
Really, which SCV oral you are giving?
Sir,
How much?
Sir, 400 mg twice.
Okay, maybe you can switch over to Valsivir 500 milligram OD, because there is a difference in availability of the pharmacokinetics differ, and when maybe once in a while there is the virus is
So-
not responding to this. So in those cases, maybe Valsivir you can try. All right.
So can the
And sorry.
Yeah, no, sorry, sir,
And
carry on.
even by giving this Asivir or Valsivir or any prophylactic, it is not 100% reduces the chance of recurrence. It's only by 50%. So if disease is still occurring maybe more than twice in a year, that becomes an indication of giving oral prophylaxis. If it is less than that, only when and it happens. And then you can find out if there is any stress factors in the patient, because fever or some mental stress, even there are so many risk factors for developing this thing. Once you try to rule out those, any immunosuppression, other things. Yeah.
Any other question? Then I'm going to ask. I think we've had a lot of useful discussion. Yes.
So you said that in computer vision syndrome to start cyclosporine early. So how early?
That's why once you are early moderately severe disease, we have mild moderate severe, then in between early to mild moderate to moderately severe. So one has to even decide what type of this thing, socioeconomics, whether the patient is going to come back or follow up. There are so many things you have to see, and just blankly starting. First of all, patient has to build up faith in you. You have to build up faith in patient that he is going to come for follow-up. So it's a long time process. Otherwise, we are just beating around the point.
Rheumatologists, once they see patients of their own also rheumatoid arthritis, they always refer patients to me for starting the
Cyclosporine. Okay, so are there any, if the company can tell us, are there any trials which are going on? You would be visiting the entire country. Which are the trials, futuristic trials which are going on? One that we are doing is comparison of Cequa versus Restasis. Second, I told you, was topical cyclosporine in fungal keratitis. Commercially.
Communication that probably low cost cyclosporine sometimes are not good to go. So rather than suppressing the inflammatory mediators, it actually aggravates them. So you should be very cautious in using and assessing your patients over a period of time when you start the treatment, anytime on cyclosporines.
multi-center. In Australia, we also have role of cyclosporine in Sjogren's syndrome.
In?
Sjogren's syndrome.
Sjogren's syndrome.
So that also is one which is in the primary stage. Otherwise, we also have in another, not in India, but in other countries, the trial is going on the fast onset of action. Let's say how fast, because the issue with cyclosporine takes 3 months. So here we have data which is 14 days. So that is still getting studied there in the countries. In India, we have this phase 4 trial going on multi-center.
One thing I have faced is that once earlier we used to think of starting cyclosporine in dry eye patient. We used to think twice, should I start or should I not start, because it may be tolerated, not tolerated. But I think with the introduction of this brand, Sequa, that fear is gone. If there is an indication, you can safely start. Tolerability is better than
I think in adenoviral, Sonam just mentioned about it, keratoconjunctivitis, it again makes a lot of difference because you can taper the steroids earlier.
We use it routinely for that.
Yeah. So
and in LASIK, I use only if the patient is having mild or moderate pre-existing dry eye, or some patients, like they following LASIK particularly, they develop very severe dry eye. In cataract patients also, those patients who have very severe dry eye or moderate dry eye before surgery, then we start it.
I think it is always useful, especially when you are doing surgical candidates or patients who are for surgery, and it may be a cataract surgery or it may be a refractive surgery, it may be other kind of surgeries also, that you do start this beforehand.
Dry eye is going to worsen after surgery, whatever we do.
The only point I think is we have to start this at least 4 weeks before, sir, and then continue for 6 months.
Definitely.
So any other question or any other
Just
comment?
One last question I have to all the panelists. I mean, many times maybe few patients following any type of refractive surgery, be it PRK or a LASIK or even SMILE, we have 1 to 2% patients who complain of deep-seated pain in the eye, so-called classified as neuropathic pain. They are just miserable at the end of depression, and few of them also have a neurotrophic induced epitheliocatopathy, which of course heals by time. But what all of you are doing for
neuropathic
these
pain?
Yeah, they are very miserable. He says, we are much better before the surgery with the glasses.
No, we have a deep seated.
That happens even following keratoplasty for keratoconus patients also. Some of these patients, they have
like
unexplained.
Also they have phantom pain.
So what are you doing?
No, that's what I'm asking. Because it has been in literature described giving pregabalin,
counseling the patient,
and pregabalin and those types of painkillers, and even antidepressants. They allocate cyclosporine. I don't know, because they say the regeneration of the nerves is abnormal. The end of these nerves become bulbous, so they are more amenable to nociceptive stimuli and all those. Even the blink leads to deep-seated pain. So I have no clue how to.
So I think we are just counseling those patients and hoping that they would adapt to their situation.
So it is easier said than done. For
Yeah.
the patient, it is much more difficult. Prophylactic, how is going?
Placebo kind of a placebo for this. Yeah.
You know, all these techies are very intelligent people. The
So
more intelligent
Manpreet
you are,
is
the more miserable they are.
Manpreet is adamant for post-LASIK patients you should give.
Ma'am, because we have found objective decrease in OSDI, TBUT, all the parameters of dry eye. We know the corneal nerves are cut. So to wait for the neuropathic pain to set in, as you said,
Even
maybe
after
too
1
late.
year, even after 1 year.
Yeah, once the process, as you said, is set in, better target them
So I
early
have
than
two
late,
patients,
sir.
even after 1 year, they are safe. They are not improved on everything. Cyclosporine, pregabalin, and all those things.
These painful patients will come with age. I'm too young to have suffered the pain of it.
So I think we've had a great discussion. The idea was this only, not to give a didactic lecture, And we would like to thank Sun Pharma for helping with this and helping with the symposium. And I think we need a large number of, more studies, especially because CEQA is there. So we can do more studies, and there were great ideas while we were discussing. I'm sure some of us will be able to take great points, do studies, and these are simple studies. It doesn't really require too much of equipment or instrument. So thank you very much, everybody, and thank you, Sun Pharma.